We all know that the healthcare industry is constantly changing, and with that change often comes unintended challenges. Many of these challenges are a result of advances in technology, an aging population, healthcare seeking to service underserved populations, changes in disease patterns, new discoveries and treatments for diseases, changes in evolving societal norms, and a desire for improved patient experience. Sherry, as my first question to you for the afternoon, from your research and from your experience, what would you say are some of healthcare's biggest challenges?
Wow. What are some of healthcare's biggest challenges? Actually, it's a pretty big list. But I'd have to say, given today's environment, that probably comes to mind first would be provider burnout being an ever increasing problem. Employee recruitment and retention. Across the healthcare industry, we all know that it's a huge staffing shortage and in short supply, and remaining staff are stretched very thin and overworked, resulting in more staffing shortages, nursing shortages, the mass resignation, and then medical professionals are actually leaving the field altogether for a career change. Then we have data access and limitations, and those are caused by regulatory, requirements coming out dictating sharing of data, but EMRs and health information networks don't speak to each other. They don't speak the same language. They're not compatible. So consequently, you have fragmented information being transmitted back and forth. So basically, one provider may not know what the patient's getting from another provider. So that's a huge challenge. And then finally, I would say claims and clinical review teams that are really, really struggling to try and keep their heads above water in processing all those requests due to the healthcare service demand being ever increasing. And the list continues. If we do a quick Google search, and my years of experience in the health plans, I should say, there's a plethora of issues. Like I said, data, burnout, staff retention, and depending which chair you're sitting in some of these challenges could be more urgent than others. Some are long-standing issues that we've seen for a long time and we've been working on for a long time, but have now become more urgent. Or some may be new challenges that have resulted from new technologies or research or care delivery expectations. And while all of these challenges are important, they all impact one another. And the healthcare industry is working really diligently to find that win-win, best-in-class solution to improve that service and delivery. But change takes time and collaboration. And as you can see, it's a pretty big list, and new ones are being added all the time.
Yeah, it's a big list, and I know healthcare plans don't have the resources to kind of boil the whole ocean. So, in your opinion, with so many challenges, is there one that you see consistently rising to the top that if we addressed it, it would have the largest impact?
Yes, actually there is. Through daily operations and at every level, be it the C-suite, claims, customer service, marketing, site visits, we hear escalated employer member complaints. It's constantly about prior authorization. It's a long-standing issue. Health plans are working on it for a long time. And the biggest complaint is that prior authorization is becoming more and more confusing and more complex. And even the annual surveys that come out every year show a year after year prior authorization rating of being one of the top 5 dissatisfiers or NPS scores that health plans continue to struggle to work with and to try and improve. So health plans are constantly being challenged to improve that prior auth process and overall experience. And actually, given the rapid changing environment and due to the pandemic and care delivery expectations, healthcare organizations and provider groups are going to face tougher competition in trying to attract and retain their members and their patients who have come to demand an experience that matches the same level of customer experience that we get from our consumer brands like Amazon. I know where my package is, or Domino's, I can track my pizza. Why can't I do the same thing with my prior auth? Why don't I know where that's at? Why don't I know its status? So we're also seeing prior authorization getting a lot more scrutiny in the regulatory field too, and a lot more attention. CMS, the federal government, state, even your accreditation organizations are starting to put in regulations that they want for you to have in place for them to re-accredit your organization, be it NCQA, URAC, Interqual. So they're all implementing those, and the prior auth impact has more of an impact on just everybody else and not just the internal organization's workings. And so that's where the big push is.
So if I understand that correctly, with year after year with prior auth being one of the top dissatisfiers for both patients and providers, if everyone's so dissatisfied, why even have prior auth?
That's a really great question. So let's take a look at it, kind of prior auth's history and its original intent. So if we look at prior authorization has been around in the United States clear back to the 1970s with some earlier HMO groups back in the 1910. And the original intent, which has kind of been lost or got caught in the mix there, the original intent of prior auth was to address the escalating cost of healthcare, but still ensure that members and patients continue to receive appropriate medical care. And prior auth actually falls under the definition of utilization management, and it's defined by the Institute of Medicine as a technique or a tool that allows payers to manage the costs of healthcare benefits by assessing the appropriateness of that request using evidence-based criteria and guidelines that were created through research and by the physician groups from the various areas and specialties. So when we look at authorization or prior authorization, from its, I should say, if we look at prior authorization from inception to current, the process was originally intended, as we said, to control healthcare costs, which primarily impacted the health plans as they were charged, so to speak, to establish contracts with providers and facilities that would agree to a group of fees or capitation rate to stabilize spend. This in turn allowed your providers to anticipate and track their revenue streams through guaranteed referrals or capitation rates. And by health plans controlling those costs, that also trickled down to your employer groups and members by helping them control their premiums. Then the next impact or intent was to eliminate or reduce high copays. So that would primarily have an impact on patients, but it also helped providers too in tracking their spend and their revenue in terms of billing and collecting additional payments based on the patient's plan. Then the next was to establish a quality care delivery system and provider group, again, primarily impacting the health plans, as they were to establish a network of primary care physicians so that each member had a primary care physician who would coordinate the care for the patient and ensure that the appropriateness of the care they were getting when they referred out met criteria, and then rewarding good utilizers and specialty providers by including them in preferred provider networks, which used to be like the stars rating. They got 1 star, 3 stars, 4-star rating provider. In addition to health plans continuing to monitor the quality of that care and what was being provided, and then trending the utilizers. The next was to ensure medical necessity, appropriateness, and benefits. So again, primarily with the impact on the health plans to establish review criteria. But that criteria was to have been developed through research and collaboration with the physicians and the physician groups from those very areas and specialties, and align those with the criteria. So they impacted how that was applied. It wasn't the health plan developing it on their own. The intent and the original inception was physicians who were providing that care helped develop that criteria from their respective specialty. And then physicians would know what it was because there was no surprises, because they already knew, because their peers had developed or they had, so they knew what the criteria was for benefit coverage. And then finally would be no surprise billing, so the patient would know, do I have a copay? Do I have no copay based on my plan type? So the big push was there would be no copay and no surprise bills, or small copay, but still no surprise bills that you had to pay. So the big mantra was it's supposed to be right care at the right time, the right place, the most effective setting throughout the patient's care journey, and then most importantly, no surprise bills for the patient. So we can see that prior auth was intended to impact multiple areas, but in a positive way. And although it was created for the right reasons, and it had a lot of good intentions, it unfortunately also had some unintentional impacts that paved the way for a surge in additional unintended consequences, making the prior authorization process feel very, very burdensome and labor intensive, I should say.
Okay. So what would you say those unintended consequences were?
Unfortunately, one of the most significant unintended effects is the increasing complexity of prior auth, which caused delays. So delays was the biggest unintended consequence of all. And those delays in turn can cause abandonment of care or foregoing that treatment for another treatment, or a drug of choice for another drug of choice that may not have had the optimal outcome that the physician was looking for. Disruptions in the office workflow. The unpredictable nature of prior authorization, is it going to be approved now? Is it going to be approved 3 days from now? Can wreak havoc on an office's normal administrative workflow. And so many practices have had to either repurpose their staff or hire additional staff to manage exclusively those prior auth requests, which increases their OpEx. And then you have provider burnout, and which that in turn is really the administrative work that the clinicians or physicians have to spend on the phone with multiple health plans. So not just one health plan now, but multiple health plans to service their, population of patients. They spend anywhere from 20 to 30 minutes if they have to make a phone call or do a peer-to-peer potentially. And so that causes a lot of delays, and it takes them away from being able to treat and spend time with their patients. And then you have claims denials, excuse me, or rework. And that sometimes is because the prior authorization might be approved for a certain set of codes or certain procedure, but during the billing cycle, another code was added because another service was done or needed to be done at the same time, and that delays payment, which causes a denial, which can cause an appeal. Again, more rework for the health plan, more rework for the provider office. And so again, the strategy behind that was to eliminate that. And because what ends up happening with that a lot of times is the physician office doesn't want to bill the patient, or the contract says they can't, so they have to write it off as uncollectible revenue or bad debt.
Okay. So what is it about prior authorization that makes it so challenging?
So I would say there are many, many factors that contribute to why prior auth is so challenging and so confusing. First of all, we have thousands of health plans, and there's new health plans being developed all the time too. And then mergers, which changes up on how the health plans run. The health plans have different requirements, forms, processes, provider networks. So not every provider network's the same. Health plans have been trying to reconcile that, but a lot of provider networks are not the same. Lots of plan variations in plan types. And with the introduction of customized self-insured plans, those they customize, so those are not your standard plans. So you just have a multitude of varying health plan types, what's covered, what's not covered, what's excluded, extra benefits. So there's no standardization in that. Non-alignment in workflows. So payers and providers have their own internal workflows, their own internal systems or infrastructure, and that sometimes doesn't align. And that causes difficulty in exchanging information between the health plan and the provider office, and the provider office and the health plan. So that can cause delays. Again, that kind of gets back to a lack of standardization between plans. Prior authorization lists. Some health plans require you to prior auth and an MRI. Well, another one may not. So that also too, some of them use MCG guidelines, another one might use Interquil guidelines. Others may have homegrown guidelines. So there's no standardization. So there's a lack of that between the plans. So that makes it confusing for physician offices with a large patient population from various different health plans to keep track of, what do I need to prior auth? What do I not need to prior auth? Or when did that change? So, and then advancements in technology that require more clinical review. So especially seen in the drug sector, more drugs, there's no standard criteria yet. So they got to review it. Is it still an experiment? Has it been approved by FDA? All that kind of stuff. Can we use it yet? So that's confusing as well. So I would say basically multiple steps. The biggest challenge is multiple steps and the time that it takes for physicians to have to spend on the phone and trying to, get an authorization or approval. Physicians reported an average of, I'm trying to think here, physicians reported an average of 30 to 45 minutes for each prior authorization that they had to submit, or waiting on the phone for 20 minutes. So that takes them away from patient care.
Right. That's a lot. So can we expect to see more prior authorization requirements?
Yes, there's an increasing demand for medical and behavioral health services. And with that increasing demand, that's more technology, newer research, newer medications. And so consequently, those require review because again, we're trying to keep down the spend, right? We still want to provide that quality care. We still want that latest and greatest that's going to have a great outcome for that patient, but unfortunately it requires review. And the AMA is actually projecting a 20% increase per year on prior authorizations, and that's just medications alone. And then while medications and then those technologies can demonstrate, like I said, an improved outcome, again, they're usually a high cost. They're often too new, and they don't have the criteria established yet for a quicker review. So those can take a lot of time. However, physicians and practices are, as you know, they've been very critical about prior authorization for many, many years and its complexity. And so they've been pushing back, and they've been calling for reform. So if we take a look at, I was going to say, actually, yeah. So in fact, in 2018, the AMA led a coalition group composed of the of AHA, American Hospital Insurance and Hospitals, and then American Health Insurance Plans, AHIP, and then your pharmacy. It was a large group, including Blue Cross Blue Shield, and then Medical Group Management Association, all calling for prior authorization reform. And that was in response to that increasing dissatisfaction about prior authorization, the process, and the burden it was causing. So in 2018, this group actually released a consensus statement stating what they felt prior authorization needed in order to ease that burden. And one of those things was to have selective application of prior auth criteria. Today, we kind of call it gold carding and trending, which we have various health plans doing that in various fashions and various forms. So selecting and implementing prior auth on those who are not good utilizers or who had low utilization trends or too high utilization trends, and then rewarding those that did good utilization with not having to do prior auth. Transparency and ease of accessibility, big complaint. Improving the communication channels so that physician offices knew, what do I need to prior auth? What's changed? What criteria does it require? What do I have to submit to get it approved? 68% of the physicians reported that it was a challenge to know or to determine if a medication required a prior auth. And 58% of the physicians reported that it was a challenge to know whether a medical service required a prior auth or not. Continuity of care, a minimum of 60 days grace period is what they recommended. Well, today, a lot of the health plans already have what we call transition of care, which is usually a 30 to 60 or sometimes 90-day window where the patient completes their care. So we actually kind of already do have that in place. Program review, volume adjustment. Basically, what are we pre-certing? Do we really need to do that? What's on the list and why? Because it's constantly changing. And then automation to improve the efficiency, which the government's got into a lot of regulating in terms of, HL7, FHIR, the APIs for patient access data and provider access data. Also the ability to electronically submit prior authorization referrals. So there's a lot of stuff that's already in the works that came out of this coalition as recommendations. We look at some of the statistics, I call it from that. So the AMA published that survey from 2018, and actually they did another one in 2021, and the results were unfortunately just as sad. What they reported was that so 93% of the physicians reported care delays due to the prior auth process. So that's not good. One of those unintended consequences. 82% reported the prior auth process sometimes led to treatment abandonment. In other words, the person's like, I'm not going to do this, too complex, or they went to something completely different. 34% reported prior auth having led to a serious adverse event for their patients. In other words, they had to be hospitalized for some reason. 91% of the physicians said the prior authorization programs had a negative impact on patient clinical outcomes, but there weren't really too many specifics around that. And then 30% reported that they felt the prior authorization criteria was rarely or never evidence-based, rarely or never evidence-based. And it's interesting because 98% of the health plans said that they used evidence-based criteria for all of their reviews. So it was kind of interesting that the perception and what the health plans would say. Then if we look at the impact on the physician impact, physicians said that they did on average 41 prior authorizations per MD in their office per week and spent about 13 hours or 2 days working on prior authorizations alone. And then 2 out of 5 or 40% of the physicians reported having to actually bring in staff or dedicate staff to exclusively work on nothing but prior auth. And then 88% described the burden associated with prior auth as being very excessive or, just high maintenance. The survey also went on to say that 26% of the physicians reported waiting at least 3 or more business days, according to AMA. And during this time, patients were unable to start their treatment. So the physicians would not start the treatment because the patient didn't have authorization yet. For many practices, these long waits also, again, added to the burden of having to get on the phone, delays in care, and it caused them to go to some other treatment, or the patient just decided not to do it. So other reporting dissatisfiers, they said too, were like the multiple steps, which we talked about in another slide, holding times of 20 minutes or more, and that 30 to 45 minutes just to complete one prior authorization. Okay. And a similar study by the American Affairs revealed, they actually said they spent 20 hours per week per medical practice working on prior authorizations, with a breakdown in time of this: 1 hour of the physician's time, 6 hours of his clerical staff, and 13 hours of his nurse's time for those prior auth transactions. And that didn't include following up or tracking them.
Wow.
And if we looked at the potential for lost or the administrative cost, you know, there's absolute potential for them losing a lot of money from this. You know, as we all know, failure to get an authorization means you don't get paid, or you get a denial. And so consequently, you know, they reported having, let's see here, if we look at the screen, if we look at, you know, 35%, they reported 35% of revenue loss due to prior authorizations. In other words, they didn't get a prior authorization. Consequently, they had to write it off. So 35% of those ended up being a write-off. And so from the chart, we see that. And so the denials also, you know, so obviously creates a denial, which we talked about, and that causes an appeal. And that in turn causes more work. And they did an average study on appeals. And so the practice said they spent about $14 per transaction, as well as the health plans having to spend another $118 per claim looking at appeals and reworking those claims. And a common problem for the offices or the provider offices is that they're so taxed with trying to balance the patient's care and the administrative workload that those claims and stuff fall out of that time frame. And so they get denied. And so consequently, that whole cycle just keeps recycling itself. And so it's a lot of work for the physicians' offices, which again, their primary focus is supposed to be focusing on their patients.
What are we seeing in the industry to address this issue?
Mm-hmm. So while there hasn't been a mass standardization of changes yet, CMS has become very, very active in looking for solutions. And the coalition's consensus statement that came out in 2018, in addition to AMA's ongoing it's called Fixed Prior Authorization campaign, it's been a real catalyst for those to take action and at the federal and state level. And those activities include health plans continuing to work toward reducing their prior authorization lists, doing an analysis and trending, doing gold carding, and implementing automation for services that you never ever have to say authorization for, right? Why am I calling in? I'm going to make this up. Why am I calling in an x-ray? I'm never going to say no to an x-ray. Okay. So they're looking at those. They're also looking at, as they start moving toward more of the value-based care arrangements, which is moving that risk over to the provider groups. They look at whether or not they do or don't want to do an authorization for those services, and they manage that risk and that spend. So the health plans are looking at delegating more of it to the health groups so they can manage that themselves. And then they're also looking at what can they do internally in terms of reducing those prior authorization lists, gold carding physicians, et cetera. Then we look at, and then CMS, like I said, CMS has finalized a rule in 2021, more around the payers that they had to implement programs and interfaces. It was the big APIs that came out for patient access, and now provider access, more interoperability for being able to submit referrals and stuff electronically. And there's more and more changes still being talked and discussed between the health plans and CMS. Then we have our accreditation organizations who are taking not only the CMS guidelines, but also they have some rules too. For example, NCQA had put out that by 2025, they'll no longer accept manual review. It'll have to be electronic, and it'll have to be, everything's going to be electronically reported. They'll no longer be able to submit a manual report. And I believe HEDIS is following the same suit. If I remember right, that they won't take HEDIS reviews anymore. It's all going to have to be electronically dated. And I think that's 2025 too. It's 2024 or 25. I'd have to check my dates again. But they're all following suit with the electronic automation wave. And then if we look finally at states are getting very much more involved with the, or I should say they're getting more on the bandwagon with implementing things. Texas, for example, 2021, Texas implemented the gold carding. They came out full force, said all our physicians are gold carded, which caused a real hoopla for a lot of people, because that's difficult to implement, especially for the health plans. Now, how do I trend that? How do I track that? So there's a whole thing put in with that. And interestingly enough, the same representatives that put the Texas gold carding in place in 2022, there's a bipartisan bill that was introduced to the U.S. House of Representatives, and it supported the Texas bill, but with a little different gold carding flavor. It is for the medical services, but excluded the pharmacy, interestingly enough, whereas the other one originally included all prior auth across the board. So that one I think is kind of still in the works, but you can see the states are starting to get involved in, putting regulations around. In 2021, they just finished putting out an approval that validated 6 months to 12 months for chronic conditions. So they kind of extended our transition of care scope, because remember I told you it's kind of like a 30 to 90 day. Well, they kind of extended that. They also put into place a much more robust denial process. And then Georgia in 2021, they came out with more transparency around prior auth, website submissions. So, and that's just to name a few, like I said, so there's more and more states jumping on the bandwagon in terms of trying to make it better. But when they do that, what happens is now all the physicians don't know, who's doing what and what do I follow? Because everybody's got something different. And so it's very difficult to maintain that.
Yeah, no, understand. So with that, so what's the answer? What solutions are there that are available to healthcare plans?
So many solutions have been discussed and considered across the healthcare industry. And there's a growing consensus that automation and data access sharing are the key to fixing prior auth. By automating the process and integrating those systems, we can reduce the need for manual input. We can help improve accuracy and efficiency, in addition to communicating with our providers and our payers more effectively. However, automation alone is not enough. Hand in hand with that, we have to also do an ongoing review of our business practices, data analysis and trending, keeping up with the industry changes in order to adopt their workflows because they're mandating it, and then adapt what we have to fit that, or coming up with better solutions ourselves and recommending those. Standardized review criteria across the board and documentation so the physicians don't have to guess from plan to plan what they need to submit. Again, communication and transparency, letting physicians know about changes before they happen, before they've submitted a request and there's a denial, right? You get a denial because you didn't know that changed, or you get a denial because you didn't know that it needed an authorization. Ongoing process improvement and workflow analysis, removing things that are inefficient or unnecessary activities and finding ways to streamline those processes. A lot of health plans are looking at what we call bundling prior authorizations. And a good example of that's like a total hip. We know that you're going to need physical therapy. We know you're going to need maybe home health. We know you're going to need DME. So instead of me having to call for each one of those things, they're looking at putting those together. So when you call for a total hip, all those things are already approved up front. And physician specialties are getting together and looking at things like that to bundle those to make that burden less. And we call them episodes of care. And so that's one of the, I think, a really good solution to, if we have to prior auth it, can we bundle it?
Right.
Let's see. And then talent acquisition, obviously finding the right talent with the right skill sets and retaining them through ongoing training and keeping them abreast of industry changes, and then upskilling the staff that we currently have so that they remain engaged and they're able to develop the skill set to be promoted within the organization versus feeling that need to leave and go to someplace else to get a higher position or salary. And then I was going to say, and then I would say finally, probably really looking at sustainable changes through establishing really collaborative partnerships that streamline your processes and minimize or remove administrative tasks that take them away from being able to focus on their primary focus. And that would be through outsourcing to a BPO, like Catalyst Solutions, do those administrative tasks and farm them out to Catalyst Solutions. If we look at, managing prior authorization, as we know, is very tedious. It's, all those administrative tasks are very tedious, time consuming. And again, like I said, they take away from the organization, be it the health plan or the primary care physician's office, which takes away from their primary focus, right? So, and, according to an MGA statistics pool, the physicians reported that over the past 5 years, they've seen a significant increase in prior authorization requests. Criteria requirements, are also constantly changing, and the provider offices struggle to keep up with those requirements and which health plan, like I said, requires what. 62% of the providers felt they don't have the technology to keep up with all this. They don't have the technology to evaluate whether a prior auth does or doesn't require an authorization, be it a diagnostic test, a medication. They just don't. And then fax and phone is still the most common way of prior authorization today. And we need to automate that to take some of that burden off of them. Can we have the systems talk to each other finally so they put the order in and they can translate it out to the health plan so that we can get the authorization for them and they can focus on seeing patients. So by partnering with these type of services like a BPO, we can help those practices save time and resources that they need for obtaining the prior authorization. We can reduce the risk of denials for them, and from getting a lack of information through outsourcing and delegating to an external vendor. And so like I said, that's really a good example of where we can partner and collaborate, and that's what's going to probably take. These people are specialists. They work on prior auths every day, right? They do it day in, they do it day out. They track them. They follow up on them. I call it, they fight for you. They fight for your authorization for you. They ensure the treatments or services that require prior auth are submitted promptly. They ensure the prior auth requests meet all the criteria for each health plan or payer before it's submitted. And it minimizes the hassle that can be created by having duplications or unnecessary work. Somebody else starts it over because somebody doesn't know somebody else started it, and it gets laid aside because they had to go see a patient. So as a health plan continues to move forward with the value-based care risk arrangements, a BPO can also help with managing, for that outsourced provider group, managing those coverage determinations and doing that on their behalf, making those decisions for them so they can function like their little review team internally. And then outsourcing allows your providers and your health plans, like I said, to return to what they do best, which gives your patients, confidence that they're getting the quality care that they need, that they have the networks that they can get the best care from and from facilities, and they are getting it timely and it's appropriate, from the providers that they're seeing. So in summary, I would say that, the healthcare industry faces many challenges, as we showed. And, as the world continues to change and continues to experience rapid advancements in technology and ongoing regulation changes, the healthcare industry is going to continue to face ongoing challenges. And there's going to be our old ones that we still struggle with, like prior auth, and there's going to be a lot of new ones, so it also becomes very evident that highly developed skills and expertise are going to be needed to solve these changes. And it's no longer going to be found in one place. And we're going to start needing to collaborate with one another and develop these partnerships and alliances that will, really help us be able to sustain sustainable change and meet those challenges that are tedious, time consuming, and really are, administrative tasks to take away from a busy health plan and provider offices alike.
No, I totally agree. So I guess kind of in summary here, as we look at kind of what healthcare plans can do, there's certain kind of constraints that are kind of being imposed upon them, either through what you've mentioned with, workforce engagement, workforce resiliency, and the budgetary restraints that a healthcare plan faces. And that those can be alleviated through partnerships and creative relationships with vendors and partners for outsourcing and staff augmentation. Really kind of focusing on the idea that these partners bring specialized skills to the table, which makes their function more resilient. It eliminates the risk of staffing shortages, and it brings a certain level of expertise that the healthcare plan might not have native to its own organization. And because these organizations generally bring a scale of economy, it should help alleviate kind of the budgetary restraints as well. You've also said that there are kind of new and advancing technologies that will be coming into the marketplace, and a lot of healthcare plans have a solid level of technological expertise, but in some of these newer areas, they're going to need assistance from someone who is a technology specialist, which is where a consulting practice could provide a lot of benefit, because this is what they specialize in. This is their area of expertise, and they can extend that area of expertise to the client to make the client's technology, the healthcare plan's technology, much more effective. Was that a pretty reasonable summary of what you're trying to get across?
Yep, I think so. Yep, yep. We're going to need to collaborate.
Collaboration.
Yep, yep.
So with that said, Sherry, the information you have provided has been fascinating. I want to thank you for sharing this information with not only those of us on the call today, but those of us who had the opportunity to see this presentation.